The future for this particular patient population that I think is really exciting is going to be Dara VRD. And the reason I bring this up is that if you go back in time, we know that these melphalan-based regimens, while are used globally because of the low cost of melphalan, the problem with melphalan is it can be slow to act, it can be stem cell toxic, it's renally cleared, doesn't necessarily work in high-risk disease, can lower blood count. So it has a lot of features that American oncologists don't like, and since we have the ability to use many drugs, we often don't use melphalan. And so when we had the first study compared lenalidomide and dex to melphalan, prednisone, and thalidomide, and that showed definitively that len-dex was superior in terms of progression-free survival and outcomes, efficacy outcomes to MPT, showing that RD is probably the better regimen for elderly patients. Then came the SWOG study that was recently published that showed that when you take patients who without an intent to transplant and do VRD versus RD, the VRD led to better response rate, progression-free survival, and overall survival. And so for that reason, VRD is really the preferred induction regimen. The problem with the SWOG study, though, is it wasn't restricted to elderly patients or transplant-ineligible patients. It was just without the intent to transplant. And so there were relatively few patients who are above the age of 65. And also, what we really need to think about for older patients is safety. And VRD in the SWOG study was given with twice-weekly bortezomib, standard dose lenalidomide, standard dose dexamethasone. So I think for transplant ineligible patients, we have already published that in our series, we looked at about 120 patients at our institution who were over the age of 70, and we found that the best outcomes really occurred with VRD. But here we gave bortezomib weekly, lenalidomide is dose reduced based on renal function and age, and lower doses of steroids. And we really had very impressive progression-free survival of 36 months, very high response rates. We hadn't reached a median overall survival. So I think this is where Dara VRD will be very exciting because previous studies have shown that 4 drugs are not always better than 3 drugs. For example, the addition of cyclophosphamide to RVD did not improve outcomes and led to more neutropenia. And so not all 4 drugs are better than 3 drugs. However, what's unique about Dara is its clean side effect profile. It's a monoclonal antibody, so it's been safely combined with both proteasome inhibitors, both IMiDs, all 3 IMiDs, cyclophosphamide, melphalan. And so we think that this quadruplet is different from a standard quadruplet. And we already see that the Dara VMP has shown superiority to VMP. So I think there's a lot of interest in this Dara VRD, and there is a randomized frontline study comparing VRD to Dara RVD in transplant-eligible patients, so we'll see what that data looks like. But at our institution, we're very excited about an investigator-initiated study with Dara VRD with dose attenuation for transplant-ineligible. And of course, the other very exciting thing that will be coming forward would be the Dara sub-Q. And that, particularly for elderly patients, will be really impressive because there's going to be super well tolerated, minimal volume, minimal time in the clinic. So I think the Dara sub-Q data are really encouraging, and I think we're all excited to see how that Dara VRD with the sub-Q Dara will look in this elderly population.